Dr. Sunita, can we start with today's session?
Okay.
Dr. Sunita,
Hello, can you? Yeah.
So we are starting our session. A hearty good afternoon to all. Welcome to our fourth session. Today we are having a topic on end of life care and it will be taken by Dr. Charu Singh. So Dr. Charu Singh will be our facilitator for today's program. We have Dr. Sunita and Dr. Rajini joining in as co-facilitators. Thank you all for joining in. Over to Dr. Sunita.
Thanks, Rajlashmi. Welcome, everyone, and good to see you all. Just to clarify regarding today's topic, we will be dealing with end of life in the context of COVID-19. Grief and bereavement will be touched by Dr. Chitra in tomorrow's session. So, because we had sent in the invite that the three topics are covered, but today will be mainly with end of life. So it's my pleasure and privilege to introduce Dr. Charu Singh, who is a facilitator and faculty for this session. Dr. Charu has more than 15 years experience working in palliative medicine. She's a professor of anesthesiology and palliative medicine. She's also got fellowship in critical care, a diploma in palliative medicine from Cardiff University and also from Flinders University, Australia. She's also completed a 3T course in bioethics by the UNESCO chair. And she was also instrumental in starting the bioethics committee while working in Amada Institute of Medical Sciences, Kochi. She's an excellent teacher, a wonderful clinician, a very compassionate person, and a truly loyal friend. Over to you, Charu, ma'am.
Thank you, Sunita. That was very generous of you. And yes, I really appreciate the friendship that we go back a long time. And good to see you here. So hello, everybody. As Chitra said, as Sunita said, my name is Charu. I want to start by first acknowledging the contribution of Pallium India in putting together these meetings for the benefit of everyone, for the learning of everyone. I also want to acknowledge the extremely hard work that has been put in by the PalliCovid Kerala group. I was a part of a couple of sessions and I saw how much of effort went into preparing the ebook and the toolkit. So hats off to you guys. And especially for today, I'd like to thank Dr. Rajeshri Suresh, who's kindly agreed to allow me to use her presentations for end of life care in the light of COVID. So I'm going to start sharing my screen so that we can move on with the session. I was just wondering how many of us have issues with technology. The day I have to present, something goes wrong. So we were extra careful today. So I will proceed with the session because I think we're already 7 minutes into this. So the idea of today's session is to understand why death is important for all of us. Death is a natural event, but it comes with a lot of pain. But in the COVID-19 situation, it is an untimely death that we are looking at, and it has its own ramifications. So providing good end-of-life care is very important, and we are going to look at some of that. Dr. Sunita yesterday would have covered preventive management, and as we go on, we will look at those also. There are certain specifications that are coming out from the government guidelines, and these guidelines keep changing every week, if not every month, about whether to wear a mask or not to wear a mask, and what is isolation, what is quarantine. So we need to look at those, and how do we provide end of life care. So people see death in various aspects. It's not something that anybody looks forward to. And I heard one palliative care physician saying that people are actually worried not about death. They are worried about the dying process and the suffering associated with the dying process. And that is something that we can address. It is important both for the patient and for the family and for the healthcare providers. So I'm going to give you a minute uh, to look at these questions that are there on the screen, and I'd like you to put down in the chat what comes to your mind about your own death. Suppose a doctor has told you you have 3 to 6 months to live because you have kidney failure or you have heart failure or something. What comes to your mind first? Where would you want to die? Who do you want to be there with you? What is most important for you? So the participants who are there, could you please put in the chat box your responses? Yeah? Yes. Very true. Many of the people want to die at home with family around them. It is a deep sleep, yes. Instantaneous, natural, at-home death. That is what my father, who's 82, says. I want to go like this. I don't want to be bedbound. Yes, someone who says it's a natural process, I think that's a very evolved statement. That's very true. But how we die is also very important. And yes, to die without suffering. Thank you so much for all this. So yes, I see that many people want to die at home in their own bed with their family. But we should not presume that others would want the same. Because sometimes the family members of the patient, they are both worried that they are going to add extra burden to the family member if they are dying at home and they are unable to provide good symptom relief. So the family or the patient may prefer to choose to die in a hospital. So we need to be aware of that majority people would want to die at home, but there may be some who may want to be around doctors who can take care of their suffering instantaneously, and they would want to be in the hospital. Yes, it is very important to say our final goodbyes, and if you have some time, 3 to 6 months, you would want to finish some unfinished business. I went to meet my parents yesterday after 3 months of the lockdown, and the first thing that they got to speak to me once they were just the three of us, my father, mother, and I. They told me what are their investments, where have they put their things, because they're both about 80. And I think there is this WhatsApp message going around that anyone over 65 should inform their family members about their wishes and about important things that they need to. So there are lots of things we can just go on and on with this. But let's come back to our uh, focus for today. So you're familiar with Ramesh, I believe. You've seen that he had certain symptoms which were addressed by Dr. Sunita yesterday, and his condition is deteriorating. So when someone is uh, in a hospital with COVID-19, they are in isolation, not necessarily in an ICU. But if the condition deteriorates, they may have to be shifted to the ICU. It may not be necessarily for mechanical ventilation, but it can be for other reasons. So when you are making this drastic shift uh, or finding the goal of care, there has to be an adequate discussion and documentation of the wishes of the patient and the family. So we will go on and see how Ramesh, what happens to Ramesh and what we can do for him. So, yeah. So why is end of life care important? Okay, when we are dying, we may not worry much. We may worry about the suffering that we may have to go through when we are dying. But for the family that's left behind, it's a huge impact on when they see how their loved one died. And if their loved one suffered and died, that negative memory will stay on throughout their lives. And it will give rise to guilt and anger at the healthcare system. But if you're able to provide a better, a comfortable death for their family members, they will switch back at some point of time to the good memories and will be grateful to God that there was not too much of suffering. So I want to bring to light to you that India, we are all right now thumping our chests and saying that India is the only country that can beat Corona, and our economy is going to be the first one to bounce back and things like that. But the Economist Intelligence Unit did a research, and they looked at 80 countries to see the quality of death. So the criteria that they used for quality of death were whether palliative care is available, what is the healthcare environment, is it a government setup, what sort of setup, is it a private corporate setup, what are the human resources available, nurse-patient ratio, doctor-patient ratio, affordability of care. Now, this is a very significant thing because right now I'm sitting in the National Capital Region, and the messages that I'm getting from friends and family members are that there is an acute shortage of beds. Nobody wants to go to a government hospital, and if they're going to a private hospital, they have to first deposit about minimum of 4 lakh rupees before they are admitted. And it's a huge amount of money even for me to contemplate paying upfront, stat, middle of the night for myself or any family member of mine. So this is something that is very relevant for our country, and that is why we are having, despite all the guidelines that have been coming from across the world, the PalliCovid Kerala group took out some very relevant points for developing countries. So just to go back and tell you, we stand 67 out of 80 countries that were assessed. And looking at developing countries in Africa, countries like Kenya, Uganda, Zambia, Ghana, Southeast Asia, Vietnam, they all came, they had a higher rank than India in the quality of death. So we are comparing developing countries, and we are still 67th. And the only reason we actually came up from this is because of presence of palliative care in Kerala, from where this resource has been put out. So yes, so I have already mentioned that it is very important. We give so much importance to someone's birth, and when someone leaves this world, it is equally important. And yes, the memory stays with the loved ones, and we need to pay attention to end of life care. I have about maybe 28 or 30 years of experience in medicine, but I was never taught about how to look after the dying patients. And if someone was dying, it used to cause a lot of panic. And I still see some of the juniors in our hospitals, they push the patient into the ICU because they don't know how to handle or how to talk or how to support the family or the patient in having a comfortable death. So, why is uh, end of life care very important in this COVID-19 situation? And what are the challenges that we are facing as compared to pre-COVID times? I'd like you to again can you please put in your in the chat box why is it important and what are the challenges? This time is very short. They're isolated. It's the isolation of the dying individual not being around with their family members. We saw what everybody wanted, and definitely, yes, not knowing what is happening, the trajectory, which way things are going. The fear of transmitting diseases to other family members. I again recently came to know that a gentleman thought he had COVID and he consumed acid. He went out of his house and consumed acid and committed suicide, and he turned out to be negative for the coronavirus. But it was that fear of transmitting it to his loved ones which ended in him committing suicide. So yes, it is environmental, the rapidity of process, the services that we are able to provide. As healthcare workers, you must have also got lots of WhatsApp messages seeing what problems that doctors and nurses are facing. So just to put it in context, yes, so you've mentioned most of these things, that it is an acute illness, very fast progression. There is no time for us to be mentally prepared. And I think this is the new C word. Earlier we used to say the C word is cancer and nobody wants to use that word. Now the new C word is COVID. And there is no time to think or prepare yourself mentally and in other ways to deal with the situation. There is very limited information as to what will work, what will not work in a particular situation. And every country is doing research, and every other day we have new drugs coming up. Azithromycin will work, such and such a thing will work. But bottom line is, right now we are only supporting the body with life support. Either in isolation, if a young person is ill without comorbidities, the body will fight the infection, or we support the body till the body is able to, the physical body is able to fight the infection. But despite putting someone on life support, they may still be going downhill and they might be close to their death. And those are the times that we have to take decisions really fast, because we can't have a lot of time. We don't know, suddenly situation may change from morning to evening also. There is a high level of anxiety among all. Currently people are, apart from being the disease being contagious, they're also worried about, are they going to get adequate health care? Will they get good quality of treatment if they go to a government hospital, or where are they going to get money if they're going to a corporate hospital? So isolation from family members is something that everyone has said, and yes, it is from our own experience that you had put out. Being with family members is very important, and here the family members of the patient with COVID would be in quarantine and they can't meet anybody else either. So Dr. Biju is saying relevance, not all patients at risk of dying of COVID are fit for ICU or critical care. Example, those terminally ill even prior to COVID, those with multiple comorbidities. Thank you, Dr. Biju. That's very important. Uh, I think triage was taken by Dr. Moira, and she would have said that there are certain criteria that every country has adopted that or based on their experience or the case series that someone who's more in age, they have a pre-existing lung disease, they have a pre-existing cardiac condition, hypertension or anything else, and the people who have chronic renal failure. They are the ones who are less likely to survive despite life support. So yes, they never get to see. Sunita Solomon has said that they never get to see even one smiling face. So in the isolation, the nurses are stressed, the doctors are stressed. In the ICU, everyone's wearing those PPEs. You can't even make eye contact. So yes, all these things which we use for supporting our patients are not possible in this scenario. And there is an acute shortage of PPE, and I'm sure you're aware that 10% of all healthcare workers in the world have died because of acquiring COVID-19. And in India, even police officers are acquiring COVID-19 and dying in an effort to keep people at home during the lockdown period. So about the inappropriateness of artificial life support, Dr. Biju has already mentioned. The decision making is difficult, and not all people are likely to benefit. And they probably, I'm presuming, my father is 82. If he were to develop COVID-19 and he would reach a hospital, nobody is going to offer him an ICU bed or a ventilator. He's 82. So that is something that is sometimes would be very unacceptable to family members who don't understand the situation and the rapidly changing guidelines that are coming in. So do you know what's futile treatment? Can somebody put in what's futile treatment? Futile treatment or inappropriate management. Let's try go on ahead. So just to first clarify, futile treatment, normally when I studied medicine, I was told how to diagnose an illness and what is the treatment that you need to give. Yes, treatment which is unlikely to benefit the patient. Thank you, Meenakshi. That is very important. We need to see what is the benefit and what is the harm. If there is no benefit and there is greater harm, then that treatment is considered futile or inappropriate for that patient. And this has to be explained to the family members and documented. Otherwise, they will feel that there was negligence or care was not provided appropriately. Yes, ventilating when there is no use. There are these ethical dilemmas that are going to come out. So ICMR, and there are now, I think, even the Supreme Court, the government of India, they have all said that it is a doctor's discretion to decide who gets a ventilator and who gets an ICU bed. And it's not an automatic process because we have to triage. We have to give the best facilities for people who are likely to benefit from it more than those who are not likely to benefit. And unfortunately, no illness looks at age, sex, the money in your pocket, the reputation that you have, whether you're a politician or a poor person, to decide who it is going to attack. And those should not be the criteria for us to take decisions. Who gets a bed? If he is a politician, he gets an ICU bed. No, not if he's above 80. So these are very difficult times for healthcare professionals also to be able to explain this to the family members. Now, there is one very important distinction between euthanasia and stopping or not providing futile or inappropriate management. The intention of avoiding futile treatment is to prevent more suffering. But in one of the Supreme Court judgments, they had used the word passive euthanasia. Euthanasia is clearly uh, with the intention of causing death. The outcome in both the situations is the same, but euthanasia is intention to cause death, whereas not giving or withdrawing futile treatment is to prevent more suffering. So the Indian Penal Code has certain sections which will protect you. Now the Supreme Court will also back you. There are lots of uh, uh, pulmonology and critical care groups which have put out guidelines which clearly differentiate between them. So it is not an issue for doctors. So yes, principles of end of life care. So let me go back to Ramesh's story and see what we can offer Ramesh if he is deteriorating. He was in the isolation ward and his condition is deteriorating and he is closer to dying. We have had to have a conversation with the family members. We cannot do it face to face. So it might be through telemedicine, video conferencing, WhatsApp. There are lots of tech platforms that are available nowadays. But what would you consider good end of life care? Like to put things in the chat box. So yes, so a good end of life care means that you don't provide treatment that does not mean the goal of care for the patient in the family. So it is very often that I have seen in my career over 30 years that when the doctors are unable to do anything, they say, please go back home. And that is a very distressing situation. But here we don't say that we are stopping treatment. We're just saying that what our treatment is intending to provide, that goal has changed. Earlier, we were supporting the body for the body to be able to fight the virus, but that is not working now and is causing more suffering. So we are switching the goal of treatment to provide comfort and symptom relief. We need to respect the wishes of patient and the close families, and sometimes it gets very difficult to enable this wish to be fulfilled. Would you send someone with COVID-19 who's dying to their home? Yes, end of life care is appropriate care depending on the patient's prognosis. And this prognosis needs to be explained to people. And the wishes, we can't guarantee, we can tell the family members that we will make sure that the patient is comfortable and use these tech platforms to allow them to see each other before the end comes. Yes, mitigate suffering. So that is one of the good ways, important ways of providing end of life care. If the person can be isolated at home, Praveen Jacob is asking, if the person can be isolated at home, we can send the patient at home. So this is possible only, in fact, the guidelines that the government has issued is that if the symptoms are mild to moderate, the person should be isolated at home, isolated in one room, so that he does not come in contact with the other people, except for given food and medicines, and they should have their own personal bathroom. For many of our patients who are suffering, the migrant laborers, where they were exposed to the COVID-19 because they were in such a huge crowd. I don't know whether if the family has just one room to live in or two rooms to live in, whether this is possible. But if the person has moderate to severe symptoms or they're dying, would you send them home? What do the government guidelines say? I'd like to request the other faculty also to put in their inputs. Yes, thank you, Sunita. That just reiterates my confidence in my reading the guidelines properly. Yes, the government guidelines across the country say that if someone is dying, they cannot be sent home. So if a patient has mild to moderate symptoms, they get in touch with the doctor over the phone. But when they come to the hospital and if they're at end of life care, they are not sent at home because they're still carrying the virus and there is still a very high possibility of the virus spreading to the other people. So someone was trying to say something.
Ma'am, you can continue, I suppose.
Okay, so yes, Dr. Rajni said that we cannot send severely ill patients at home, unlike other diseases, because the viral shedding is very high. Yes, and I found out how are they when a person dies in the hospital, because the body secretions are going to be they will come out of the body, so they would all be carrying the virus load. So we need to protect the person. So they say that the body is wrapped in plastic. It is sprayed by sodium hypochlorite, and then another plastic covering with a zipper is put on top of the body, and it is sprayed again with sodium hypochlorite before the body is handed over to the family. At one time, when the number of cases were less, and in the Western countries, the cremation or the burial was being conducted by healthcare professionals and the government agencies involved. But with the overwhelming number of cases that are coming up, this is something that is people are finding very difficult and are handing over the body to the family. Of course, they are not cremated or buried with the plastic covering, which would be very infectious and would need to be appropriately disposed. So there are a lot of issues around challenges around providing end of life care. So end of life care in any other condition would be looking at the patient's comfort, focusing on their nursing needs, their food, hydration. We look at their medications. Suppose someone is on a cholesterol controlling medications, it's irrelevant at this point. We stop those kind of medicines. And of course, we continue to review continuously. And we need to provide effective communication. And I think that will vary from place to place, state to state, institution to institution, whether it is possible for a doctor to talk, a social worker. You can use technology for communication. And how do you provide psychosocial support? This is what is the traditional end of life care plan. But in COVID, we have to discuss the goals of care, if required, transitioning patients from intensive care to palliative care, to make the family understand that the palliative care is going to focus on keeping the patient comfortable and not making him suffer. We never thought, I was never taught how to provide good end of life care till I actually came into palliative care. And to provide psychosocial support and bereavement support are new responsibilities that the healthcare professionals have to take on at the time. So we have to learn more skills, and I hope this series is going to help you to do that. So Mr. Pranab Basu has said only shocking scenarios that the family members are not allowed to have a last look due to the contagious virus. That is very true. So all we can do is connect them through WhatsApp or I don't know whether telemedicine and all these things are possible, but there are other technologies which are coming up fast. Google Duo, Microsoft also has some platforms. So at least that much is what we will be able to provide, but not that is usually done in the usual conditions. So what are the strategies for effective end-of-life care symptom management? Dr. Sunita has taken symptom management for you. Can you put in the chat box some of the symptoms that you remember from yesterday's session? Pain, yes. A whole body aching pain is there, yes. Which is the first sign? Breathlessness, very true. And that's breathlessness is one of the symptoms that people are told when you have breathlessness, go to a hospital. Fever, that's the most commonest symptom, and that's why you have this distance temperature checking happening at every other place. Anxiety, agitation, very, very true. We'll quickly look at some of the symptoms here. So you have covered all of these. Maybe I think secretions and pressure ulcers are something that, yes, thank you, Meenakshi, for adding that to the list. And yeah, for managing even symptoms, we do still require personal protective equipment. So I believe Sunita would have covered this. Yes, Sunita, you would have covered breathlessness. I was not there yesterday, so I'm a little out of the loop. So at one time they said that morphine should not be used for someone who has breathing difficulty, but now it is an accepted standard method, and you can give 5 milligram of injection morphine subcutaneously or intravenously. I remember from one of the previous sessions somebody had asked, why not intramuscular? And the answer to that is the absorption from the subcutaneous site is faster and better than the intramuscular space. Fentanyl is available in certain places, and some doctors in the ICUs would prefer to use fentanyl, especially because fentanyl has no excretion through the kidney, whereas morphine gets excreted through the kidney. And if someone has chronic renal failure, superimposed with acute renal failure, because they are dehydrated, they are having fever, they're sweating, they're losing salt, they have lung disease, we're giving them diuretics, they actually are in a negative balance, and then you have an acute and chronic injury. So you have to be very careful when you're using morphine, or you can use a combination of midazolam. And you can keep repeating these drugs till a person says he is comfortable. So symptom is what the person is going to say. You're not looking at the oxygen saturation or respiratory rate at this point. You're asking the person whether they're comfortable. And if this is going to be an irreversible thing, then we probably have to start morphine and midazolam as a continuous infusion. I'm sure there will be more questions related to this. Please go back to the toolkit, look at the algorithms, look at the resource that is available on Pallium India's website, and we can, you can in your feedback put in questions also if there is scope, and we can address it at maybe tomorrow. So agitation is one more thing, and there are two types of reasons for agitation. One is something that we call delirium. When someone is very sick, they're elderly, they're in a ICU, there are noises all the time, there is light all the time. You are not aware of what day or time it is, and that's called delirium. You have delusions, you have hallucinations, and the drug of choice in that scenario is haloperidol. Haloperidol, we normally start with about 2.5 milligram. 20 milligram is the maximum dose that you can give in 24 hours as a continuous infusion. But you would normally titrate it to a patient's requirement and add midazolam to prevent the agitation. The agitation can also happen because of intense anxiety or fear of what is going to happen. And there haloperidol does not have much role. that midazolam and other benzodiazepines to reduce the level of anxiety might be beneficial. Roshni has asked a question. Renal impairment is one of the complications of COVID. How do you adjust the dose of morphine for the patient? So, where in many situations, if I don't know in how many places there is continuous infusion pumps available. So the next best thing that is suggested is to give subcutaneous boluses of morphine or even sublingual, because it takes lesser amount of time. There is a risk of aerosol generation, but even when the nurse is very close to give a subcutaneous injection, the distance between the patient and the nurse is very less. So how you would adjust the dose of morphine is by increasing the gap between the doses of morphine rather than changing the amount of morphine that you're giving in. And yes, if there's fentanyl is available, then you switch to fentanyl. So what do we do about pain and fever? This should be simple. I'm waiting for your answers. Paracetamol. Absolutely. Thank you. And what dose with paracetamol can be given in? How much of paracetamol? How frequently? Anybody? Just for the sake of time, I'm going to go ahead that 500 milligram to 1 gram every 6 hours can be given. Yes, thank you, Meenakshi. 1 gram 6 hourly can be given intravenously, or if the person can take, intravenously, I guess would be much better than suppository or anything else. And if required, since we are looking at end of life care and comfort, the maximum dose that is recommended is 4 grams over 24 hours. We may, if the fever does not come down, we can go up, knowing that there may be a harm that may have happened because of increasing the dose of paracetamol. But at that point, it is very important to control both pain and fever. And paracetamol in doses of 1 gram works both for pain and for fever. But at 500 milligrams, perhaps it just works for fever and not adequately for pain. If someone is on opioids for either breathlessness or for any other pre-existing condition, suppose they have cancer, they are on opioids, then we adjust the opioids for the pain. And it's the patient's, someone wants to add something?
I request all to stay muted. Ma'am, you can continue with your class.
Okay. So the most important thing in this situation is that since then we are expecting that the person might be delirious, agitated, it is very difficult to assess what is bothering the patient the most. So patient assessment is a challenge, and that's where the role of specialist palliative care people come in. But one of the Canadian palliative care physicians, immediately after the pandemic was declared by WHO, had said that the next pandemic is going to be the shortage of palliative care physicians across the world, because it's a relatively new branch. But I'm very optimistic that this the toolkit or the resources that have been put together by PalliCovid Kerala will be useful for all of you to develop these palliative care skills to help your patients in COVID-19 situations, specific COVID-19 situations. Yeah. Renal function can affect the neurological function and our ability to assess pain. But paracetamol normally does not have any direct effect on the kidney, or is not either excreted through the kidney. So there is less interaction between the kidney function and paracetamol, whereas NSAIDs would be a bigger complication here. So that is why we are not mentioning it. So any thoughts on secretions that a person will have? We normally say that the cough is a dry cough, and you should be using cough suppressants to prevent that dry cough. And one of the indications for people to go to a hospital is when they start having productive cough. Where else can the secretions come from? Anybody? Or the faculty? So if a person is getting very sick, yes, morphine can help in cough suppression, especially if it is a dry cough. Fluid overload, yes, because it is already a lung-related illness, and we tend to keep a negative balance, which backfires in causing an acute renal condition. But keeping them on a positive side will cause pulmonary edema, or will cause increased secretions from the mouth or the throat, even in the GI tract. And if a person is unconscious or disoriented, they may not be able to swallow. And these secretions can be very disturbing because the air going in and out of the airway will go through these secretions and will cause a very noisy breathing. And so normally what happens for secretions is that we do suction. But suction can be very painful. And if anyone is an ENT doctor or has had a ENT condition where they had to go, I get a gag reflex the minute someone puts something on my tongue to lower it down. So suction, doing a deep suction is very difficult, and sometimes the secretions are very low down that your suction catheter will not reach there. And the sharp edge of the suction catheter can actually cause damage to the mucosa there and can cause bleeding and pain. So the better way of managing is to position the patient in such a way that gravity may help in drainage of the secretions. So putting them in a lateral position or maybe a head-low position, which may not be the ideal for breathing difficulty. But if you're sedating them or giving them morphine and midazolam for breathlessness, you can do a head-low position. In ICUs, they also say that you should ventilate a patient in the prone position because that improves oxygenation, which will again help gravity to bring out the secretions rather than you're poking something into the person's throat. So there was a debate about secretions. When there are secretions, what do? You try to suppress them, and you can use these three medications that are available. Glycopyrrolate, 0.2 microgram is available in 1 ml. You can give it 4 to 6 hourly, either intravenously or subcutaneously. The route does not affect the change in the dose. Or you can use Buscopan, which is hyoscine butyl bromide. And last option is atropine. But yes, this ophthalmic, this is, I'm forgetting the terminology. But yeah, the ophthalmic solution can be put on the tongue and can reduce the secretions from the oral cavity. If you give it intravenously, they'll probably have palpitations and tachycardia, which might be also distressing. So atropine can be used locally by giving it on the tongue. So the thing that we need to remember is the minute we dry up the secretions, they become thick and more difficult to either drain out by gravity. And dry mouth can be as distressing as secretions. So we may need to keep the mouth moist by giving small droplets of water, measured doses. In ICU, suction is not used for spraying of aerosol, which will deteriorate. Yes, that is true. Anything close to the head end, whether it is intubation, it is suction, it is tracheostomy, all of these will result in greater aerosol generation, and they are not advocated at this point. So that is one very good valid reason for avoiding suction, apart from the suffering that it may cause the patient. So we also need to focus on the dry mouth, and fungal growth can happen in a dry mouth very fast. Some people may also say that, you know, if there are secretions, we should give something like N-acetylcysteine, which will loosen the secretions and they can cough them out. But if the patient is very sick and cannot cough it out, it is going to go further down the respiratory tract into the alveoli and cause greater breathlessness. So that is not advocated. To use medications to make the secretions thin enough for the person to cough out is not advocated in the COVID-19 situation. So yes, pressure, we are focusing on so many other things, on the life support, that we tend to forget about the patient's pressure sores if they're too sick to move in their bed. There are certain things that we also ignore. How is the endotracheal tube fixed? What is it fixed with? There are some people who are allergic to the material that is used for fixing an endotracheal tube. The nasogastric tube can actually bend the nostril and cause an injury there. If you're giving oxygen through masks, there are various types of masks. There is non-invasive ventilation, there are non-rebreathing masks. They can cause a pressure ulcer on the nose. So we need to pay adequate attention to all these things also, because they are reasons for causing suffering. And while in the regular patient in an ICU, we may advocate a 2-hourly change in position, when someone is at end of life, a very rigid turning of the position is probably not advocated, because again, it brings the healthcare provider closer to the patient more often than required. And the time period may be very short because of the rapid deterioration. So we can be flexible, but we have to look individualize how often we need to turn the patient. So Dr. Rajni has said, hydroxychloroquine is used in mild to moderate disease. So yes, in initial stage, if not cardiac contraindication, but in severe cases, later stage, hydroxychloroquine is not so useful. Skin care for patients at points of friction of oxygen delivery devices, bridge of nose, yes, behind the ears, cheeks. So we covered that. I'm not sure about the hydrochloroquine. ICMR was very, please correct me if I'm wrong, because this is not my area of expertise. The ICMR had come up saying that hydroxychloroquine, an antimalarial drug, is very useful in preventing, but people who've done trials and have used hydroxychloroquine have found that there were greater side effects than any benefit.
If I may just comment on that a little bit.
Rajni,
so,
yes.
As of now, the ICMR has recommended that hydroxychloroquine can be used for prophylaxis for doctors who are taking care of COVID patients, or for family members who are in close contact. In terms of treatment, there was some controversy about hydroxychloroquine causing more side effects. Those 2 studies that were released in the New England Journal and Lancet were subsequently retracted, because the data that was given on this was by a company called Surgisphere, and it was not verifiable. And now there are ongoing other studies. Again, the benefit that has been seen is modest, so it's not great. Again, in the subset analysis, what they found is in the early stages of the disease when it is used, and not in very high doses. So the doses that the ICMR has recommended is 400 milligrams twice a day on day 1, followed by 200 milligrams twice a day. Those are safer doses, keeping monitoring of the side effects as ECG and things like that. And even so, we've not got great evidence. As long as it can be used safely with monitoring, it's used in the mild to moderate stage of disease, not so much in severe disease.
Thank you, Dr. Rajni, for your input. That was a very vital point that I forgot to mention, that yes, hydroxychloroquine is recommended as a preventive dose for healthcare providers who are looking after COVID-19 patients. But when I was going through a lot of literature earlier, I saw some of the cases, the data that they had put out, that the death mortality rate is 50% and not 97. Those kind of studies had only 24 patients in their as the subject.
So
I
which agree. Is very, that's the French study of Didier Raoult. So the whole thing is that right now the verdict is still awaited.
Yes.
Which is why I use all the qualifying terms that the evidence is modest at best, the benefit is mild to moderate at best. And it is only to be done with monitoring of the cardiac stuff. If you ask me, I haven't taken the prophylaxis because I'm not convinced of the profile. My feeling is that if something hasn't shown benefit in treatment, I worry about whether it really will be useful in prophylaxis. There's lots of confounding variables in those studies. So I completely agree with your initial statement, Dr. Charu, that no matter all these drugs that have been said, right now we are looking at good bedside clinical care, which has stood the test of time as being the most important thing.
Yeah. And yes, and honestly, like I said, I'm not very sure about hydroxychloroquine and other medications that people are saying. I've read antiviral drugs and you can use antibiotics and all that stuff. There is very little evidence, and I think we should probably ask for help if we have to do that, because it's not possible for us to know. I think Rajni is a pulmonologist, intervention pulmonologist. So she would be up to date, and thank you, Rajni, for enlightening me with this information. So this is something that we need to, I believe in the last 6 months, over 100 publications have come out on COVID-19. And many of them do not have a very strong basis. So just a couple of days back, everywhere they were flashing that dexamethasone is the medicine that is has come out as the first drug against the coronavirus, and people started celebrating. And all of the doctors were a little skeptical, because in an antiviral situation, you're giving steroids, you're reducing immunity. There is a chance that it may backfire and may make the situation worse. And there is an acute phase where there is a cytokine storm. I'm using a very technical term. At that point, dexamethasone may actually help. But all these messages that are circulating on WhatsApp and these have to be taken with a pinch of salt. And if you don't know, it's better to refer to a colleague in that area to ask for help. Because of course, we don't want to do any harm. While if we cannot help, we should not be harming the patients with our treatment. So now that we have time, I'm not sure how many slides are left. So Ramesh's condition has worsened, and the team is calling a video conference, and the family says that we want to take him home for end-of-life care. So what do you think we should be doing? Should we be sending him for end-of-life care at home? How do we ensure that he gets a good quality end-of-life care? Am I audible better than before? Somebody had mentioned in the chat that they cannot hear me.
You are audible throughout, ma'am.
Thank you. So Can someone tell us what is the government directive about COVID-19 patients being sent at home? Yes, so Rajni is saying that we are assuming that Mr. Ramesh has received all these. So he is now in the end of life care situation. So yes, patients are advised to go home and isolate themselves when they have mild symptoms. That is what is being advocated, because our healthcare system is going to be overwhelmed. But if someone is at end of life, it is very difficult to provide them with adequate symptom relief and prevent their suffering at home. And at the same time, to train the family, they would also require personal protection equipment. Otherwise, they are as likely to cause to get infected by the coronavirus and end up with COVID-19. So at present, the government directive is not to send patients home if they are end of life in a hospital. If anyone has a difference of opinion, please put in, because I know every week guidelines are changing and I may not be 100% up to date. Yes, the person cannot be sent at home because they're still they can pass on the infection to many other people. And I want to ask about the last question. How will their neighbors react? What do you think is the situation in society at present about COVID? There is a huge amount of anxiety, fear that has, I think, we all tend to think of the worst the minute we hear of COVID-19. We've seen the developed countries being overwhelmed with the amount of patients that they are getting, and the number of deaths that are happening in developed countries. So naturally, considering it's a developing country, the fear and anxiety is at a very extreme level. And in my housing society, there is a child who turned out positive for COVID-19. And there are about 60 flats in that building. And people are now scared just to use the lift, and they're using staircases from the 14th or the 15th floor. So that's the level of phobia that is happening. People are getting very aggressive, and much of the anger and aggression is the healthcare professionals are at the receiving end of this. So yes, you would have also heard that people, doctors who are staying as tenants are being asked to vacate the house. Doctors are not being allowed to come and see a patient at home. Any household where there is an elderly patient, the family members are absolutely phobic about how they're going to pass on accidentally, despite all precautions. Cleaning mobiles, handling cash, all these are ways through which COVID can be transmitted. Rajlakshmi, I'll need your help because this is stopped. Oh, okay. I think, yeah. Sorry. So, appropriate training of family member. I don't know how effective this is going to be, because if the family member is so full of anxiety and grief, how much information that we are imparting to them and how much they are able to retain it is going to be very dicey. How do we give them medicines can be managed, but how to use medical gadgets is not an easy task to do. We will have to teach people complicated things. Disposing waste materials is another big problem. And because of these conditions, that is the government recommendation is that the person is not sent home when they are end of life. If the patient is in a vegetative state, what will be the role of palliative care? When you say vegetative stage, you mean because of COVID-19 or a pre-existing condition?
Due to COVID-19 or any other situation, any other disease?
Yes, I guess if a patient is in a vegetative stage, I am not sure that they will actually be the triaging process. Who gets what treatment, the appropriate treatment. So the person who probably is in a vegetative state has a zero quality of life or a very poor quality of life, and then putting them on, sending them to the ICU and a ventilator at a cost of say 1 to 2 lakh rupees per day is going to be futile and will increase the suffering both of the family and the patient. So I guess here again, it is only going to be symptom control through palliative care and informing and educating family members and supporting them with small doses of information rather than an overwhelming 1 hour session that we are having today. So we've covered these. We need to keep up with the latest guidelines, and I found it a Herculean task because since February to June, most of the guidelines have turned around and gone for a toss. So yes, utilizing local healthcare authorities. Yes, you wanted to say something?
Thank you, Doctor.
You're welcome. So utilizing local healthcare authorities, and I have to say I've worked in Kerala for about 17 years, and I have seen the strong healthcare system that they have, the ASHA volunteers, the panchayat level support that they have, and that is why they were able to contain the Nipah virus when it had come. And the first case of COVID-19 that came in India was from a student who was evacuated from Wuhan University. And Kerala, when it started off, Kerala was the state with the maximum number of patients. And I don't know, I think it's probably 8th, 10th, or even lower than that, because the healthcare system, the local healthcare authorities managed to trace every contact and quarantine them. And so this is again going to vary from state to state. This is possible. It might be very difficult to think of certain parts in UP, Bihar, Jharkhand, where there is not a very strong structure, and there are other factors, social factors, which interfere in providing good health care or empowering the local healthcare system. So I'm not going into politics at this point of time, so I'm not mentioning anything here. So, effective communication, we've been mentioning all along, is very important, and it is very challenging at this point because things are deteriorating and developing very fast, which you all have mentioned earlier. There's no time to absorb all the information. We have barriers to communication. We cannot even, with the PPE, we cannot even come in 1 meter's distance of the family while wearing PPE, because our PPE may be coated with COVID-19. So how do you communicate delicate issues or discuss goals of care from 1 meter across? So again, we'll have to depend on technology. We need to explore the concerns. We have to give information, but we have to give it in small doses which can be absorbed and not overwhelm them. We need to acknowledge that there will be a very significant emotional reaction. So we need to support the family Yes, last time I think grief was covered as a separate topic, but I would like to tell you that when in COVID-19, we have said that death is a natural process, but in COVID-19, it is not a natural process. People are dying an unnatural death. And when you lose a person because of an infectious disease, in which there is a possibility of cure, and you lose a person, then to deal with that grief is very difficult. And we can, I'm using very simplified terminology to say that this type of grief is not normal grief, it is a complicated grief, and we may require to pay attention and identify and refer such patients to mental health providers, psychologists or psychiatrists, or even social workers, to help them deal with this situation. So yes, so while the patient is in isolation, family is in quarantine, and uh, a person may be in one state and the family member in another, and because of the lockdowns, nobody can see each other, and there is this stigma. Oh, my next door neighbor has, oh, COVID-19 has reached my uh, my residence association. It has reached there. So the panic level keeps going up, and I guess the Arogya Setu keeps updating you on the number of cases that have turned positive 500 meters or 1 kilometer in your radius, etc. But yes, we can always follow up uh, after a patient passes away. We can follow up with the family through a phone call. And trust me, even receiving a telephone call from a doctor or from a social worker is seen with a lot of gratitude from the family's side, that they have not been forgotten. They were not just one more, they were not a statistic, but a person and a family. And just by making a phone call, we can acknowledge the existence of human beings and emotions and thoughts and feelings. So I think that is something very important. Yes, I think we've discussed the ethics of end-of-life care, and we've discussed the futility and inappropriate treatment. And there is another aspect to that. So if a politician comes to All India Institute of Medical Sciences and he expects a bed and he expects that he gets a ventilator, there is someone who's younger, who does not have comorbidities, who would be denied of a ventilator and an ICU bed, and who has a greater chance of recovery. So we also have to look at the larger uh, uh, concept of ethics here in this situation. Yes. So thank you, Dr. Dinesh, that being a social issue, we can actually utilize communities, educate communities, bring them on board, and help them disseminate the information, and also perhaps use them to provide bereavement support to family. That is a very important point. Thank you for bringing it up for all of us. That we can empower our communities. And if you go back to the previous slides, how much is the involvement of community in palliative care is one of the criteria on which they've decided the benefit of, on the quality of end-of-life care that is provided in a particular country. So the involvement of community is very important. So we are almost coming to an end. In the final hours, if someone is appropriately managed, the family members and caregivers feel some kind of satisfaction that they were not able to save the life, but they were able to prevent a lot of suffering. There is a final gift giving, letting them slip into the arms of death, according to certain philosophers, rather than struggling and dying. And there is a strength, getting any knowledge will give you a little more confidence in being able to handle this situation. Whereas in an improperly managed, it is distress all around. The patient suffers, for family, the impact on them will be there for a lifetime because they've seen their loved one go through a lot of suffering, and they feel frustrated, helpless, guilty, angry, and there is going to be a huge amount of post-traumatic stress disorders that we are going to face at the end of this pandemic, when the end is visible. Right now, I cannot see when it is going to happen. So our final take-home messages that whatever we are doing, even when we are providing life support, we still need to be aware of the discomfort that comes with COVID-19, and we need to provide symptom control. Appropriate treatment according to whatever the guidelines suggest. Triaging, looking at what is the general health status of a patient before he acquired the illness. What was he bedbound? What was his age? What were his comorbidities? Things like that. Communication and support to family. Thank you very much. I'm open for questions. And I would request the other faculty to please pitch in when we have the questions coming up.
I think I'd just like to say one thing on this, that sometimes, especially in the Indian context, family members worry about discontinuation of certain things. So family tends to worry about, oh, we're not feeding him, we don't want him to die hungry, so if Riles tube feeds, or if even the question of someone's not eating comes up and you say, oh, should we put a Riles tube? In a situation like this, we can counsel them and say that food and feeding will actually make him uncomfortable, or else you will make him uncomfortable. So just explaining to them that the measures that they are worried about, he should not be thirsty, he should not be hungry, will be taken care of by the team through appropriate palliative care measures, and helping them to understand that it's their way of expressing love, the concern for something that they're not getting, and let them know that the family members, any discomfort will be taken care of.
Thank you, Rajni. That is very important. We need to reassure the family. And feeding is one issue that normally comes up in most of our patients with palliative care. Yeah, and end of life care, yeah, in COVID-19 will bring this up. People are more aware because of technology these days, and they are aware of what is CPR and what is ventilator, and why aren't we doing it? Why aren't we doing CPR? Is it legal? Is it illegal? And my answer always to do not resuscitate is, it is given in medical textbooks, and it is the decision of a doctor whether CPR is going to be beneficial or not beneficial, and has to be explained to the family. And if it were a question of law, whether do not resuscitate is a legal issue, it would be given in law textbooks and not in medical textbooks. So it is a medical decision, but putting it on the family that you have to tell us, should we do this or should we not do this, is being very unfair, because they don't have the capacity to take a decision. So we have to help them. We have to facilitate the decision making by perhaps saying, for my father, I would do this, or I recommend that we do this because this has these advantages versus the harm that may come from that. Thank you, Rajni, for that input. Biju? Sunita? Anything you want to add here?
I think the most important thing in COVID-19 end of life care really becomes a lot about listening and communication, because for both the patient, the family members, and even for the doctors, there's a lot of distress that doctors go through handling the end of life for patients, knowing that there is this, they have the responsibility of being the bridge. So listening, compassion become the most important.
And I think the best way these days is resorting to telephone calls. And which again brings us back to Biju's presentation that majority of communication is non-verbal, and over a telephone you cannot express your non-verbal, you cannot have the eye contact, you cannot have the smile, but the tone that you use, the pace of the words that you use, what is it that you're conveying can help over the telephone. Just making an attempt to make a telephone call itself might be seen in positive light
Yes.
by the family members as still being supported.
Yes.
So I'm happy to take any, I think all the faculty who are here are happy to take any questions from here. How much time do we have left? We do overshot by 5 minutes. So I presume that your questions are answered. And if you have any questions, maybe log in early tomorrow and put up your questions in the chat box so that we might answer your questions through the chat box while the presentation is going on. Because this is, again, for me, this was a challenge to teach through a virtual platform, use Zoom and use screen sharing. And so, yeah, this is a learning period. We are all learning new things. So, thank you all for your patience and for joining us in this group. So we come to an end of the session. Thank you all. Thank you, Rajni, Riju, Sunita. Thank you, Dr. Dinesh, for being a part.
Thank you, Dr. Charu, for that wonderful session, and thank you, Dr. Rajni, for pitching in every time for the chat option and giving a reply to every chat thing. So thank you all for joining in, and we can see you tomorrow with a session on making sense in distress. It will be taken by Dr. Chitra. So, like Dr. Charu has said, you can send us the doubts, whatever you feel like, whatever you want to know more, to our email ID or even to a personal chat. So we can direct to our faculty and we will get a reply to you for sure.